Dr. Clair is going to give the next presentation on what devices are available and what we're looking forward to in thoracoabdominal repairs.
So Rod asked me to just put everybody out for the afternoon. So I'm not really going to talk about cases. I have nothing really that conflicts with these devices other than to say that I'm talking about a number of things that are not currently available for use in the United States. So Gore has designed an ascending aortic graft. It's a modification of their descending thoracic aortic graft, which will allow treatment of the ascending aorta, a little more flexible design, designed to treat both isolated aneurysms and dissections. They will be running what's called the ARISE-2 pivotal study. The objective is to assess the safety and effectiveness of this ascending stent graft in the treatment of lesions involving the ascending aorta and aortic arch. These will be either isolated lesions, pseudoaneurysms, aneurysms, or penetrating ulcers, or dissections, either residual or chronic dissections. There will be 3 arms to the study: a surgical arm, which you see on the right. There'll be a primary arm consisting of 70 patients who will be high-risk surgical patients in which this will be used for the ascending aorta, and a secondary arm that from 50 to 150 will utilize this device in conjunction with the TBE to remodel through the arch potentially if possible. Again, these will be high-risk surgical patients that will be enrolled. The primary safety endpoints you see here: aortic rupture, lesion-related mortality, disabling stroke, which I think is an important in paraplegia as well. Primary effectiveness is technical success in the absence of reintervention, and secondary endpoints, as you see noted here. TAMBI is a device that I think many of us have looked forward to for a long time. Good to see that it was just approved by the FDA with a release date expected sometime in early summer of this year. Obviously, this will provide for us options for patients who have complex aneurysmal disease for off-the-shelf treatment. The device itself is an aortic component with specifically designed branch grafts, pre-cannulated 4 ports for visceral and renal arteries, and staged deployment similar to Gore's C3 delivery system. This is what the device looks like when it's in position with a bifurcated graft extended beyond it. Obviously, this will extend repairs in some situations above where they potentially need to be, but for an off-the-shelf solution for patients with emergent problems, I think all of us have been waiting for something like this. The Gore branch device you've seen already. I won't spend a lot of time talking about that. Obviously, the proximal extenders can be used in conjunction with the TBE as part of the ARISE-2 study as well. I'm going to move through this just because you've seen this information about their Zone 2 treatment arms already. And I apologize for that. Terumo, in addition, has been pretty active in terms of looking at new technologies. You can see they've introduced low-profile thoracic endografting for aneurysmal disease dissection and acute traumatic dissections, but as well, they've continued to be involved and engaged in hybrid and surgical repair of aneurysmal disease through the arch as well, introducing a number of devices both here and in Europe for use with arch aneurysms. And you can see the release of these products that has come over the past several years. They are now beginning a trial with the Trio graft, utilizing a purpose-built fenestrated stent. And the idea behind this is to combine a computerized fitting model with custom-made fenestrations that the physician can make at the time of the procedure to do an on-table fenestrated graft. So CT evaluated with AortaFit, Ben Starnes' company, which has been modified somewhat to provide you with a template. That template is placed over the graft. There are fitted systems for creating these fenestrations, and then a reloading tool which will make reloading the graft into its standard delivery system much more rapid than anything those of us who are doing back table fenestrations are utilizing right now. In addition to this trial, they've also released the ThoraFlex hybrid graft, which allows reconstruction of ascending and arch disease with perfusion and with frozen elephant trunk placement distally. And these products, I think, have made at least some inroads into treatment for ascending aorta and arch disease in these complex patients as well. And we look forward to incorporation of these. This is the extender grafts, which can be used to more rapidly create extensions into the arch branches or where other places where they might be needed. This is a stent graft that extends into each of the branches through the arch, which can allow creation of a much more rapid arch reconstruction than individually suturing to each of the vessels. This is a somewhat novel device designed to try and enhance and optimize the treatment of thoracoabdominal aneurysms and perhaps save some time for the surgeons as well. This is essentially the first hybrid technology for thoracoabdominal repair. Doesn't require cardiopulmonary bypass because it maintains perfusion. Basically what happens is during the procedure, a graft from this device is sutured onto the iliac artery. The device then, through a cleared segment of the aorta, is introduced through access directly into the aneurysm wall and expanded within the supraaneurysmal aorta. This allows perfusion of the distal aspect of the aorta, and then each of these branches can be individually introduced and utilized to minimize ischemic time doing isolated branch reconstructions to viscerals and renals in a staged fashion, and then ultimately to the contralateral iliac as well. The Nexus device is currently in trial. They're close to completing enrollment. This is a single branch arch device which has been utilized for both dissection and aneurysmal disease. The device is 20 French in size, comes in a limited number of sizes, which decreases skews that you have to maintain. There are distal extenders. The device itself has an interlocking mechanism to keep the ascending component in contact with the arch and descending component. Very flexible, long delivery system, which has to be introduced from the groin through the arm itself. This allows no issues with wire wrap, as you can see with the single branch device. It's introduced in a through and through fashion from the groin out through the innominate artery and then positioned where the ascending component is advanced beyond this. In their initial trial or assessment, there was a 3.6% incidence of disabling stroke. In preliminary data from the TRIOMPH study, which is now enrolling at up to 30 sites with 60 subjects with chronic dissections and 20 subjects with aneurysmal disease. Again, these are the sites throughout the U.S. that are doing that. An early look at this shows that these are typical patients of what you'd see with this complex aortic disease. Early mortality at about 7.5%, disabling stroke, and 0%. Renal failure and 0%. So pretty favorable results, at least with preliminary data on looking at this. These are the types of patients that can be treated. There's a long segment in this video that's a delivery portion. I'm not going to go through that, but I think you can see a good idea of what the device looks like. You can see the wire through the aorta and out the innominate. The device is introduced with initially a graft into the innominate artery and then the ascending component added to it. This is a completion CT for this patient. You can see on the left a plug placed in the left subclavian and an arch debranching, which is done as a separate procedure in these patients. They are advancing or working still on a dual branch device, which will likely be introduced in trial within the next year, hopefully as well, and I think will dramatically add to what we can do as well. Thank you.